During the normal aging process, the nervous system becomes more vulnerable to illness. It's important to distinguish changes that are due to aging as opposed to those that are due to illness. For example, the diminished strength and agility are a normal part of aging. However, localized weakness would be only attributed to disease.
So the gerontologic considerations for structural and physiological changes, they start off in the brain, and the issue is that neurons are lost, which causes a decrease in synapses and a decrease in neurotransmitters. This causes slowed nerve conduction, which then in turn decreases the response time, which makes makes them harder to comprehend things and more likely to fall. Also in the brain, the ventricle size increases to maintain the cranial blood volume, but overall the cerebral blood flow and metabolism reduce, which causes slower mental functions. In the peripheral nervous system, myelin is lost, which causes slower or decreased nerve conduction speed. For visual and auditory nerves, they degenerate, which causes a decrease in vision and hearing. Nerve cells in the inner ear decrease, which causes balance issues, and again that goes with the brain, the slowed nerve conduction, so they're at a high risk for falls. Deep tendon reflexes are decreased, and they may even be absent in some of the gerontologic population. Hypothalamic function changes cause reduced stage 4 sleep. In the autonomic nervous system, the system has slowed responses, which causes a reduced pupil response rate, and the pupil response rate may also be absent in older patients who have cataracts. Oh wow.
Set, go. For geriatric motor alterations, there's reduced nerve input into muscle, which contributes to reduction in muscle bulk, with atrophy most noted in hands. Changes in motor function often lead to decreased strength and agility with increased reaction time. For example, gait is often slowed and widened. This can cause difficulty maintaining balance, which predisposes the older person to falls. For example,
Okay, so for sensory perceptions in the older adult, first they're going to have a decrease in their tactile sensation due to a lower number of sensory receptors, and this will result, or this might cause them not to be able to identify objects by touch because they won't have feelings in their fingers, and they also might not be aware of their location or their body movement because they're going to have less tactile cues coming from the bottoms of their feet.
Let me get the door for you.
And then they're also going to experience a degeneration of their visual pathways, and this is going to cause sensitivity to glare, and then decreases of peripheral vision, and a constricted visual field, which results in disorientation. And this is especially at nighttime since there's no light. So just to increase safety, make sure that you are using night lights and have a safe arrangement of furniture that's really familiar to the older adult. They're also going to experience a loss of hearing, and this is going to result in confusion and anxiety, disorientation, misinterpretation of environment, feelings of inadequacy, and social isolation. And then finally, they are going to experience a decrease in their sense of taste and smell. And so this could cause weight loss and a disinterest in food. And so this is just really important to make sure that you have working fire alarms wherever the older adult is staying, because since they're not going to be able to smell as well, they might not be able to detect smoke if there's a fire.
The older adult patient may feel cold more readily than heat and may require extra covering when in bed. Reaction to painful stimuli may be decreased with age. Because pain is an important warning signal, caution must be used when hot or cold packs are used. The older patient may be burned or suffer frostbite before being aware of any discomfort.
Mental status. Although mental processing time decreases with age, memory, language, and judgment capacities remain the same. You should never assume a change in mental status to be a normal part of aging. Delirium is often seen in patients who have underlying damage to the CNS or are experiencing an acute condition such as an infection, adverse medication reaction, or dehydration.
There are various nursing implications when dealing with a gerontological patient. One of the priority assessments is assessing risk for falls. And so just looking for how well the patient is moving, their muscular strength, and along with assessing for falls, just also assessing for the different physiological and structural adaptations that were already aforementioned, such as decreased motor flexes, visual senses, and auditory. So when explaining procedures or explaining information, talking slowly but loud enough so that they can hear, and kind of talking closer but not really shouting into the patient's ear, and kind of leaning in and giving them the opportunity to process what information has just been given, not talking too fast, and the ability to ask questions. So, for example, if I were to take this patient's blood pressure. Hello, Mr. Baines. I'm going to be your nurse today. This is a blood pressure cuff, and I'm going to be putting it on your arm, and this will measure your blood pressure for you. Do you have any questions? Do you kind of understand what I'm going to be doing? So I'm waiting. And I wait for his response, give him the opportunity to ask questions. And those are basic nursing implications for dealing with gerontological patients.